my father faced death. He died of prostate cancer about 4 years ago. I think during that period of time, in the months before his death, he and I actually did have quite a few discussions about spirituality and the existence of God, things like that. And he was quite introspective about meaning and purpose in his life. I think this happened to my father. This happens to, I think, most human beings. When one faces death, facing death is like facing a wall. It forces you to turn around and look back at the life that you lived. And the real task for human beings who face death is to look back at the life that you've lived and find some way to accept the life that you've lived. It's once you've been able to accept the life that you lived that you can then face death with some sense of peace and equanimity.
How does the therapist or the psychiatrist use a patient's spirituality? Or do you first try and assess the depth of that spirituality, and then how do you use it in treatment?
Well, I'll be honest with you. I think that even amongst psychiatrists who work with medically ill patients and psychiatrists who work in settings where they're dealing with patients who have life-threatening illness like cancer, it's quite common for psychiatrists and therapists to not delve too much into these issues. They're focused on trying to assess a constellation of symptoms and signs that would meet the criteria for a specific psychiatric disorder. They're looking to see if the patient has a depression or anxiety, and then they're trying to treat a specific psychiatric disorder. I think it's much rarer, unfortunately, for therapists, psychiatrists, other mental health clinicians who are working with patients who are facing life-threatening illness to actually try to understand a patient's sense of their view of their existence, their place in the world, their religious beliefs, their beliefs about what's meaningful and purposeful in their lives. And so I think it's quite important to engage in such a conversation. For example, I think it's rare for psychotherapists, psychiatrists to talk to patients about dying. We had one of our plenary lectures today from Dr. Yalom talking about death anxiety. And I think it's something that's avoided. People don't want to ask questions out of fear of upsetting patients, but I think what our obligation is to not so much force such conversations on patients, but to invite conversations by asking questions. And so I think these questions are quite important. And our job is to try to understand what is a patient's particular worldview, what is their view about their place in the world, in the universe, do they have a religious life, what sort of things give their lives a sense of meaning and purpose, what do they value?
What if the psychiatrist has no sense of, or therapist has no sense of his own or her own level of spirituality and tries to avoid it? Does this mean that the care or the outcome is likely to be less successful? Or is it possible to solve problems that humans bring to therapists without delving into the spiritual side?
I think that that a certain level of problems can be dealt with if one completely avoids talking about these sort of basic existential spiritual issues with patients. There's a sort of superficial level of problems, sleep disturbance, anxiety problems, perhaps depressive symptoms that can be ameliorated with pharmacotherapy, other kinds of therapy. But I think the experience for patients and for clinicians and the outcomes are not as rich or as robust unless one starts to deal with those issues as well, because these existential concerns are present always. They come to the forefront when patients are confronted by threat like cancer illness or life-threatening illness. And so they're present, they're just beneath the surface. I sometimes think of it as a psychiatrist who's talking to a patient who's depressed and doesn't ask the patient whether they're having suicidal ideation out of fear that by bringing up the topic, it'll somehow give the patient the idea of suicide. So you can assess, a psychiatrist can assess a patient who's depressed and never ask that question. And you may give the right treatment, you may provide the right therapy, but if you don't bring that up, you're missing a very important component. It may turn out to be a tragic error if you don't bring that up to assess it. But you might get away with it. And the same thing is true in terms of bringing up these issues of spirituality. You may be able to benefit patients to some degree, but you don't really optimize the kind of benefits that patients can achieve in work.
How does a psychiatrist therapist work who is of one religion work and or religious belief work with a patient from another,
yeah,
and still talk about matters of the spirit?
Right. I think that's a very good question. I think it's a very critically important question. And a related question is whether this, in fact, is the domain of physicians, psychiatrists, and not so much the domain of clergy. I think that when I talked before about spirituality being a construct that involved concepts of meaning and or faith, if one looks at faith as being a religious component of spirituality, and one looks at meaning, those things, those relationships, the connectedness with others, love, etc., that give a person, enhances a person's sense of meaning and purpose in life. If one thinks of that as a sort of a secular, non-religious component of spirituality, then meaning becomes a secular, non-religious language in which physicians and patients can talk very deeply and meaningfully about spiritual or existential issues. And it's the basis of a psychotherapeutic intervention that we've developed at Sloan Kettering, and we've been testing in clinical trials, an intervention called meaning-centered psychotherapy, where the focus is on discovering sources of meaning, reconnecting with sources of meaning despite the limitations of physical illness or time-limiting illnesses. And so the language of meaning becomes a secular language of spirituality, so it makes no difference whether there's a mismatch between the religions of a patient and a physician, or whether a physician is non-religious, the patient is religious, or the other way around. So it's a way of talking about spirituality in a universal fashion.
There was some controversy a few years back, I think, about some psychiatrists who were devout in their own religious beliefs and attempting to swerve their patient towards the same,
right,
in the same way.
Right.
What was the outcome of all that?
I really don't know what the outcome of that was, but
I assume it's not exactly good
it's not
practice.
something I would advocate, no, and I don't think it's a particularly effective way of helping patients. I mean, we're not in the business of religious conversion, and so I think I would recommend avoiding that for psychiatrists, and I don't think it's necessary, and I don't think it rings true for many patients. I think, what I sometimes do, I must say, is that I've worked sometimes, I've had patients who were nuns and priests, and were quite religious, and were in fact religions that had a religious belief that's quite different than my own. I grew up in a Jewish culture, Jewish environment, and what understanding that religious beliefs were important to these particular patients, it wasn't unusual for me to talk with them about how their religious beliefs either helped them or caused difficulties for them in terms of coping with illness. For some religious patients, their religious beliefs are brought into doubt when they are facing suffering and pain and the potential for death, and they have, I guess, a crisis of faith.